Good morning. Okay. So this is actually the first time I've stood up in front of an audience and actually talked about this. So I'm not sure how it's going to go. If you think at any point I'm becoming too technical, can you raise your hands and I'll try and become less technical? Go with right hand. If you think I'm not being technical enough, because there will be those in the audience who would perhaps more, could you raise your left hand? And I'll try and adjust as I go through the presentation to do that. So, thank you, Keith. Thank you for the introduction, Zahid. So where are we? Why are we doing what we're doing? So the engagement process that we had on the digital strategy that ran from summer of last year until the end of the year, the expert panel that Keith mentioned, but also the Health and Sport Committee, identified that while there were things which were constructive and positive in our digital technology, there were many problems, and the problems tended to be experienced by people using services and people running services. So while we could say that the things that we had purchased and that we were running or that we had created had been done properly, as a system, they haven't been working effectively, and they are difficult to engage with. So we can see a number of challenges across the system. We have a number of very big common systems that we use to run hospitals or primary care or within community services. Local government uses social care systems. But what we find that when we look at them is that these systems have often been extensively customized. They've been changed, they've been adapted within local systems. And that's been done generally at the request of clinicians who think that there may be a way in which we could do this part of the process a bit differently. We might ask for a different form to include information which isn't recorded elsewhere. And each of those have meant that the technology within our systems has become quite customized, and it's become quite fitted closely to how services are delivered. Our challenge then becomes when somebody who's in one part of the country requires care in another part of the country. It becomes very difficult for the information to flow with that person from one place to another place. So simply because the way in which their data has been recorded and held means that the information, as you might expect with a consumer product, that you're in Fife and you're watching Netflix and you go to Glasgow for the weekend and you can watch Netflix and it looks the same. That's not how your health data tends to work. So we have a system where the way in which it's evolved over the last 10 or 15 years has effectively created islands of data and an absence of interoperability. And that makes care difficult. So as we went through the process, people told us stories about how that impacted on their day-to-day lives. People told us about how there'd been a delay in receiving an elective procedure, an operation in Lothian, because it had taken 6 weeks for their information to transfer from another health board area. People told us that information that was significant about their care wasn't available whenever they attended at A&E. We hear about the difficulty in getting information about anticipatory care plans and about other key information within the system, in that while we create information and put it into the system, it's not routinely available across the system. For people who work within our system, I don't know who you follow on Twitter, but many clinicians have got multiple logins. I did a session last week with Penumbra and talked a bit about this, and at that, one of the people around the table told me how his daughter is now a second-year trainee in AIR, and as a consequence of that has 6 different logins to be able to interact with the 6 different information systems that she has to use on a daily basis. So we haven't quite got to the point. In some areas we've got password-style things which enable us to have a single login, but once we've logged in, we're still interacting with 6 different data systems behind that. So the fact that you don't have to remember 6 passwords doesn't mean that the data is then equally available. So data is held in different stores across the piece. And that means that what we see in terms of the people who come and talk to us from SMEs, from the voluntary sector, from industry, is much of the time they're coming to talk to us about one of 2 things. One is there's a whole category of products out there which look to stitch together our unstitched together system. So people looking to sell us processes which enable us to actually work with the complexity of what we've created. And the second group are the ones who are trying to build innovative new products that enable people to live the lives that they want to live, or to assist carers or clinicians or social workers or voluntary workers to work with people. And their concern is they find it remarkably difficult to actually bring new products into our system, because you have to customize it so many different times to join to so many different bits of the system. So our system isn't open to innovation on the basis of the barriers that you have to pass. So that's broadly that set of issues, which aren't about the flashy new app or the thing at the edge of technology, which are about the core infrastructure of what we have within Scotland, became a major focus of, I'm not sure if that's me. Is that better? It wasn't just me getting the ringing noise there, was it? No, okay. So it meant a major focus of the work that we were looking at through the development of the strategy was this core infrastructure, was to get to a point where the core infrastructure that's supporting health and care, interacting with councils, interacting with the voluntary sector, interacting with people like you and me, would be able to do three key things. It would be able to make information creatable and deployable at the point of care in real time, so that at the point where you're seeing the clinician or where you're logging onto the system to do something, the information which is required to do something is there and doesn't have to be rummaged around in 6 different systems, written down on a bit of paper and then typed into a different system, which is much of our experience. So that's the first component. The second component is the architecture should be predictable, so that as people develop products and as we add products, that those products can be, that innovation can be accommodated with the minimum of friction. You know, the intention shouldn't be that for every new product that comes onto the system, we spend 3 times as much customizing it to fit our system as we did buying it, and that's core. And the third issue is that we should be able to work with data at scale, both for the purposes of research, but for management information, so that we're able to use the value of the information within the system to provide better clinical care, so that we can learn what works best when we're offering care to people. And again, at the moment, because data is everywhere, that we have no single source of truth, the challenge with that is it makes it extremely difficult to do. So that's where the idea of the National Digital Platform came from. In terms of where we are at the moment, we are hosted within NHS NES. Within NES, we will have a board, a sub-board of the board, which acts as our level of governance. And what we've been doing with that is bringing people with expertise in digital and innovation onto that board. In that our view is that we require particular challenge which is based on expertise. So we've invited, and he's accepted, Geoff Mulligan from Nesta to be on that board. We've also invited Angus McCann, previously the IBM director for UK, onto that board. He's a member of the... Do you want to do... Am I becoming too technical?
No, I wasn't.
Which one? I've forgotten as well. Can any... Rights to...
Is it all men that are on the board?
Are all men on the board?
I think there was all boring men. I was going to say, let's look at...
So in terms of the... I don't know yet, because we're still waiting to find out which are the 2 non-executives who were appointed from the...
Okay, so sorry about that. I've probably preempted what you maybe were going to say.
I probably wasn't going to cover that. So at the moment, in terms of the people who've agreed to be on the board, those people who've agreed to be as non-execs are men, but I'm aware that women have also been invited to be on the board, but we don't know yet whether they will accept. I think it's probably just timing, and I could be behind the times on that. So it will be subject to a board of governance within NES. In thinking about how we do the work to create the platform, there's a number of things that we need to have. We need to have that governance in place. Our intention is also to create the capability to manage and run the technology within Scotland. At the moment, the way in which digital technology is managed and organised is largely by being externalised to vendors, to large international companies who provide components of the system, often at significant cost. Our view is, just as in the same way we provide other services as public services, we should provide our digital technology as a public service.
Two women on the picture, they're patients and nurses. Sorry, they've just got another woman on the thing, so it looks like one woman.
So just to add,
I'm sorry, that's really, I've got to say, I'm not heckling, I'm speaking out. There's two women doing the caring, and there's men doing the leading.
just to say, we did try and get the panel generally balanced. When someone had to drop out, and so it's two men on the panel. Throughout the day, actually, there's more females speaking.
All right, so they'll be when all the men leave after lunch.
No, they're not. It's not. Hopefully, they won't leave after lunch. But just to say, we won't take that as a learning point. But throughout the day, the majority of the speakers are female. Just to make that.
Not at the moment when I'm here.
Well, we have
some leaving after lunch to go parliament. There are women's leading and doing the talking.
Well,
hey!
points.
Sorry, I'm trying not to say anything.
So the NDS at the moment is in the process of recruiting the people who we intend would build and manage the system within Scotland. We've appointed a Chief Technology Officer. We are out to advert for senior programmers and other programmers to be involved in the development of the process, and we expect that as we go forward that we'll be doing three things. There'll be areas where we'll be looking to develop and build the system. There'll be those areas where we'll be able to buy off-the-shelf products that we use as part of the system, and we intend to use them as an off-the-shelf product. Our objective is to get beyond the requirement for extensive customization. And then there'll be those areas where we want to partner with people who bring particular types of expertise which aren't available to us within our system, or which aren't products off the shelf. So within that area, we are working with people from a number of the universities in terms of work around things such as how we manage and organise things like test results, because it would surprise you, but we have 20 or 30 different ways in which the same test might be recorded within the system across the country, and the way in which the information is held. And that's quite different from imaging technology, where because of the fact that we've got these giant machines that produce images, that's become quite which cost a lot of money, that's become quite standardised. So again, working with people who can bring particular expertise around that to do that. And in terms of this, we're also looking at a number of principles. So first of all, our objective would be that where possible, we will build in the open and to open standards, in that we think one of our objectives is to move beyond proprietary approaches to healthcare architecture. Our intention is also to focus on the cloud and use the cloud to the extent that is possible. And that's quite interesting, because in government that's been a relatively rapid turnaround, in that if we go back 6 or 7 years, there would be a reasonably strong antipathy towards using the cloud. So in the conversations that we've been having with people such as the National Cyber Resilience Centre, it's interesting to discover that they're effectively, for just about all of their data, using two clouds. They use the Azure cloud for Office 365, and they use Amazon Web Services for everything else, and they are advising on cyber resilience. So HMRC, Department of Justice, organisations across the centre of Whitehall, and public-facing delivery organisations. So we would expect to place our data in the cloud. That supports mobile technology, it supports interoperability, and it supports the ability to work at scale and flexibly. So at the point in the year when you're requiring to do more business, you're able to ramp up what you've got available. When you're doing less business, you're not paying for data systems that you're not actually using. Also, in terms of thinking about building at scale, in terms of the expectations, so the ability to deploy data and information wherever you are, the ability to process information as it grows, and if we think about some of the information that we hold, it requires remarkable processing power to be able to work through things like image data. And looking throughout all of these processes to use an agile development process. So As I said at the outset, one of the challenges that we have is the way in which the technology has developed in ways which is very tightly connected to how services are delivered. That means that we have the challenge that as we begin to think about standardizing technology as part of the process of looking to ensure that care pathways are similar, that requires changes in how person-to-person services change as well. And one of the interesting things which increasingly is coming out of the literature and experience is that's where most things go wrong in technological change. Most things don't go wrong with the technology. Most things go wrong at the point where people are not brought with the process to do the learning and to be part of the process by which the change takes place. And that applies right across healthcare systems, social care systems, and right into your world. We're seeing at the moment the process that the Karolinska Institute in Stockholm, one of the most well-regarded healthcare systems in the world, they get to nominate and appoint the Nobel Prize winner for medicine. Their technology change has just gone significantly pear-shaped on the basis they were unable to bring clinicians with them, and it was identified as being a top-down imposition of a particular solution. So that service change component to it becomes really important. In terms of the roadmap, I'll do 30 seconds on that. The analysis that we've been working on throughout the summer basically tells us that the future probably looks quite different in terms of the architecture that we're using. So at the moment we're hundreds of systems knitted together with integration layers and things like Ensemble, password logins and physical workarounds like copy and paste and things like that. The future looks different. The future looks identity management for staff, so an understanding of who is on the system, identity management for patients, but it's also being able to work with data probably where it currently sits, but as though it's a single system of data, and then having products that run across the system using, again, standards in respect of interoperability and clinical data standards. And the challenge to get from where we are to where we need to get to is immense. We've put together a group to manage that process, but we anticipate that we will do this part by part. There'll be elements that we start with. We might start with something like child vaccinations, because it's one of the issues which we need to do a bit of work on at the moment, and begin to build out of particular use cases which build the understanding of how the technology works, but also create the capability in the system to take forward the change. And that also allows us to ramp up in terms of the capacity that we've got. But we've brought together a group which includes a number of the e-health leads from Scotland. We're bringing in representatives from local government, and at this stage we're focused on those things which would be integral to the platform in terms of managing that bit of the system. Our objective as part of this is, at the end of as the platform develops and as standards become more common, the products that enable us to interact with the voluntary sector, with care providers who aren't social care providers as well, will become available to us. But that's not here now, and that will take time to get to. So that's about where we are. Over the next month or so, we are working through the preparation of our first business plan. We technically started on the 4th of June. We were originally meant to start at the beginning of August, so we actually, and this is quite rare for government, launched 2 months early. It was quite a soft launch. You'll have not seen us announce a big sum of money. We haven't made a big claim that we're going to put an app in your pocket that by January will enable you to book a GP appointment. Our intention is to do stuff and to talk about what we've done rather than to make big claims ahead of doing things. We think we've got the method, we've certainly got the support to do it, and we intend to build the capacity.
Okay, thanks very much. So Geoff and Keith will now take questions on the strategy and the platform. My colleague Doro will come around the room with a rolling mic. If you can introduce yourself, just your name and the organisation you're from, So opening up the floor to questions on the strategy and the platform. Okay, first question.
Hi, my name is Alex Solomon. I'm a member of the Scottish National Action Plan. So again, I'm the person with experience. My question is just about are you involving people with lived experience at the highest levels and at the beginning, not bringing them in halfway through or at the end?
So we think the process of product development and implementation, so the process by which we build the bits that interact with people, can only be done effectively if you do that in conjunction with the people who will use the product. And that's a big change. So for the process that we've had for how we procure software previously, has, and the general model has been that you'd have something called a requirements group that would meet for a year or 18 months and would basically write down all the different things that the system had to do. And that might involve somebody with lived experience, but then that goes into a procurement, and then the procurement produces a result, and then at a period after that, the solution is implemented. And basically, after that requirements things, users aren't really involved. People who use the product, and we are then given whatever comes out of the procurement at the end, which in some cases can be up to 5 years after that initial piece of requirements work was done. Now, that might be surprising, but we understand that technology moves relatively quickly, and so that effectively often means that we're buying things which are out of date by the time that we implement them. So we can only do it by involving people who will use the product. That's how technology works everywhere else other than healthcare.
On the board, so you want people with experience on your board that actually identify.
So I'm just going to take a question from the Turning Point. Thank you.
Hi there, I'm Neil Richardson, Chief Executive Turning Point Scotland. Geoff, I recognise the complexity of what you're talking about, and I also recognise that in procurement terms, often complex deliveries, procurement as it stands doesn't often lend itself to provide the agility or flexibility needed to deliver. And I just wondered if you kind of have a view on that and whether or not Brexit might offer any opportunity, either in terms of legislative change or political bravery in pushing the envelope.
Yeah, it's difficult to see Brexit offering us any opportunities, and ultimately we don't know where things will go with that. I think that's partly comes back to the the proposition that we have a different approach to buy, build, and partner. So at the moment, quite often what we find ourselves doing is buying, as we buy individual products, say. At the moment, we have a contract for track care, which most health boards have, which is the hospital information systems. And that comes not just with the product itself, but it comes with the support and the technology around that, but then also comes with things such as data hosting. And then we also then purchase and do work ourselves to integrate it with the rest of things. In the future, our model is more that while there might be things that we would want to buy, we would want to buy them off the shelf on the basis that we were able to drop them into a system, and that means that they would be things that already exist, so they're not subject to a two or three. And here we're thinking, of the building blocks that you probably wouldn't see. So this isn't the front-facing app that sits in front of the doctor or the patient. This is the core architecture, but it's built in a predictable way that allows us to do the agile work there. So I think we're a lot less likely in the future to see that style of procurement as the way forward. I think it's more likely to be purchase, development ourselves, and partnership. Even where we have, and we're doing work at the moment with Microsoft around 365, there we will work very closely with them, but at the end of that process, we will have control of what we've bought. And we will be effectively the managers of what we've bought. So I think it's looking to a different style of approach, and that's the idea, that we should be able to manage and run our own technology, that component of it wouldn't be outsourced.
Mary Owens from Parkinson's UK. Really, really interested to hear about the development of a national platform. Sounds great. I'm just wondering, playing devil's advocate a wee bit, I'm involved in quality improvement on the ground, and I'm thinking, how do those two things go together? Because quality improvement on the ground is about making very, very small changes, adapting systems to suit needs locally, and that can work really well. But
Yeah.
how does that fit with the ability to have a big platform that serves everybody?
So I think it's I've got so much to say on this, so because this is really so much of the work that we've done within Scotland over the last 5 to 10 years with IHI and other partners has been around microsystems change. It understands that services are local, and in terms of actually building better solutions and support for people, you need to do that within the locality, and you need to be able to draw on just whatever you happen to have around and tailor it to what's there. So that's still true. At the same time, if you're looking at things which are pathways which run right across systems, so as we move to elective centres, the idea that if you require your hip done at some point in your life, that it wouldn't be done just down the street, but it'll be done 2 health boards away. That means you need a data system that runs across that. So, and this is it. So we need to be able to do both, and it's not an either or. They're just doing different sorts of jobs. And I guess if you think of us a bit like the App Store, we're the store on which you sit the products, and the products is where that micro engineering happens in terms of the customization, but you need the store or else you can't get the product, and that's part of it. The other side is, at the moment we have relatively little outcome data within our system, so while we can track how fast something happened and if it happened, and we can probably tell you how much it cost, and we might even be able to tell you where it happened, we can't tell you about the degree to, we can't say how much people benefited. We can't say, did they feel that they had more control over their life after they had gone through this process? Did it make them feel more connected to their community? Did it make them feel safer? So one of the core things that we're looking to build into how we do the work is an outcomes module to enable us to create more data about people's experience of what happens within the system, not just did they get the operation or not. And that's also quite, because that's a sort of data that we haven't been able to create within the way in which we manage and organise data. So and I think that's a big step forward. But I could do more, but I think you need both.
Sorry about the feedback that you get on the microphone there, Geoff. Can anyone hear okay? That's good.
I'm just glad you didn't put your right or left hand up, because I honestly couldn't remember which one I said was which.
If you haven't got any questions from the back of the room, are there any burning issues that people want to raise? That's it. If you've got a question, thanks.
Sorry, I just had a question for Keith, actually. Miriam Watts from Marie Curie. So I was just interested to see the digital health and care strategy. What importance have you given to the training of people around maintaining communication when they're delivering that healthcare? Because one of the barriers we find is that as soon as you put something, a tablet or anything in the presence of when you're delivering that healthcare, you lose that personalisation and how you keep that at the forefront.
So workforce skills is a key part of that. So I think it's as part of that consideration is what's best practice in terms of delivering communication, delivering person-centred care, using that technology, making sure that doesn't get in the middle of the conversation. So, for example, I guess one of the examples would be in a GP surgery where the lack of that data coming to a GP before a consultation as to what's this person about, and we've done some work with Zahid and the Alliance that you would have the ability to provide a bit of a personal profile, what's important to you, your interests, etc. So that GP could be, if you had the time in a very busy schedule, would have a bit more information of you as an individual, so he could step away from his notes, from his records, from prompts that are there, and have more of that conversation. So yeah, we very much don't want technology to be there as a barrier, so it can be there to support the conversation, but the important bit is the conversation, not the bit of technology in between, if that answers the question. But I think it's something that professionals are going to have to adapt to. So yeah, maybe that's more of the soft cultural things that we need to bring out as part of that workforce skills, is not just the ability to be able to use the information and to be able to access the records, but how do you make sure that doesn't get in the way?
Yeah, can I offer something on that as well? So the Wachter, who did the review work south of the border, in his book, The Digital Doctor, identified that as part of the process of implementing Epic and Cerner in large American systems, the amount of time that the doctor spent looking at the computer screen went up by 20%. So they moved from spending about half the time with eye contact with the patient. Has to be to turn that the other way around. People go to their clinician to see their clinician, not to watch them type. And I think that takes you into issues such as speech to talk. We are also seeing one of the things that you'll have seen south of the border, the work that Babylon have been doing. One of the way in which they a part of their business model is because people have actually done the triage ahead of speaking to the GP. The GP has got the first 6 minutes of the conversation generally done before he appears on the screen. So using technology, just as Keith said there, to have access to information before, but it has to be the objective of any change within this that it enables personal relationships to be built. Because if it's a barrier to that, we will have failed.
Hi, Christian Keith. I'm also an allies involvement member with lived experience, and I'm a former dental care professional myself, but I'm kind of interested in whether we could have a shared patient record and how much we can build on that, especially with the importance of self-management and accessing other third sector services, that we would be able to add into that ourselves what we're doing and build up a bigger record, a bigger image of what we're actually doing in the community.
So I think that's certainly something that we would want to do. It's been piloted elsewhere. It's in place in other places in the world, and I think it comes back to the idea that this is actually your record. Your healthcare records are your healthcare records. We may manage and hold them, but they are your possession. They are your property, and on that basis, if you would want to be able to have your information held there, whether it's in text, whether you've decided that you want to log your steps, if you want to track your sleep, we should be looking to facilitate that. So at the moment, because of the almost impossibility of giving you access in a meaningful way to your data, it's very hard for us to do. But that's why we need to resolve these issues around data connectivity.
Is that because of security, really? Or?
It's really because, so if you think about the bits and pieces that we'd need to put in place, so the first thing we'd need to do is have a mechanism by which, if you're doing this electronically rather than on paper, you'd have to be able to demonstrate that you're you. So have any of you renewed your passport recently? And been able to do so with just your driving license? You used to have to fill in all these forms, but now you can authenticate with another document. So you have a methodology that enables. So we're doing work at the moment across the Scottish Government on how you can do what we call, in our very, very particular jargon, online identity assurance. So Department NHS Digital have just launched a pilot on this south of the border, which looks like the methodology by which you sign up for a Monzo bank card. And you can actually show yourself to be yourself to the system in about 3 minutes, start to finish of the process. So you need to be able to do that. We then have to have what we would call your record in a sensible place for you to actually look at it, and it's not, because it's in all those different data stores all across the shop. And we then have to be, in some ways, be able to tag what you would add to it into your record so that if somebody else looks at it, because I guess that's part of the intention, they would see what you've done as well. So that data curation, that identity assurance, and that data management all have to be in place. And those are core bits of infrastructure that we want to build.
Is there a way of doing the other way around? The patient has it and then they allow access to certain individuals?
That's in place, and that's certainly one of the models which is out there as a possible model in terms of effectively being you holding all of your record. How you would then build that back into the system is quite, it's probably equally complex, but we could certainly look at that as well.
Okay, I've got time for one. It's been covered. So is there any other questions? Okay, just one question from me. I think obviously you've got a timeline, and I've seen the blog for the next digital server, just focused primarily on health and starting with a few small projects. When are you going to start engaging with social care and third sector and actually trying things out there?
So we have 11 councils at the moment are out for renewal of their local social care systems. And I guess this comes back to this, one of the questions that we have more generally, is that we used to, at the moment I say we used to, I suppose I'm putting myself 2 minutes into the future here. We go out and we buy a GP system, and we buy a community health system, and we buy a social care system. And then we create multidisciplinary teams that sit in GP offices or social care resource bases or health centres, and they then sit down there, and some of them will be there with their 3 computers, effectively reflecting the fact that they are working with 3 different systems, and that means we can't afford to give them mobile phones, but we can give them 3 laptops. We are only still in some places on Windows whatever, with Office whatever, because we can't afford to upgrade it, but you've got 3 different versions of it because you've got 3 of those as well. So one of our questions is, are you actually looking for something which is an activity and record management system which is for people? Because the person looking at that might be a GP or a community nurse or a social worker or a social care worker. And so that takes you into a different way of actually thinking about what the product should be. So it's not a GP system anymore. It's a system which enables you to do manage records, create activities, produce referrals, dispense medication, and other people do those as well as GPs. So creating a system which just does it. So the architecture needs to. So we are involving social care. Are involved in the transition group. We have at the front of our mind those 11 proposed procurements for new social work systems across Scotland, and I guess in the same way that we're looking hard at GP systems and other systems, we would like to think differently about that. So they're in the process now.
Well, that's great. Thanks to Geoff and Keith.